Well, welcome everybody. I'm Pat Price. I'm co-founder of the Global Coalition for Radiotherapy, and we wanted to welcome you today to our webinar on essential standards in cancer plans. We're really excited to hear from the panelists today who've given of their time, and also we want input from yourselves. So just a few bits of housekeeping. If you could use the chat to introduce yourself, give us your name, location, contact information, and if you'd like to share. Also, chat would be a great way for all of you to contribute today, as we have many people attending in a short amount of time. And remembering this will be the first phase, and we will collect the comments and analyse the data and intelligence together today, and then we'll be having our second follow-up webinar. And I know as we're a global community, we recognise the barrier of using English for some, so we do hope you can chat and feel comfortable, and we want you to share your ideas and thoughts in your preferred language. So it's with great pleasure now I hand over to Shadi, our other co-founder of the GCR, who's going to take us through what we're planning today. Thank you.
Thanks, Pat. Just really quickly want to go over our plan for this project. It's in two phases. In the first phase is this webinar where we hope to present the subject, really come away with understanding the issues and the structure of what we plan to do, focus on listing issues to be addressed in the framework we are developing. So for example, planning, monitoring, quality, etc. From this, we'll take away some objectives, examining existing guides for radiotherapy planning and developing the high-level framework. In phase 2, we plan to have another webinar, second webinar in June. We'll share more details on that at the end of this call. There we plan to present the framework that we've developed based on this first webinar. We will address the issues to be considered in a more detailed plan. So human resources, equipment, quality, with the experts, the physicists, therapists, radiation oncologists, really the whole radiation oncology team. We will then break out into working groups, so a task to develop some task force objectives. So that will include a draft detailed framework, which will have equipment, workforce, operations, quality, education and research. Then secondly, aligning radiotherapy planning with other elements of cancer control plans. So the prevention, screening, diagnostics, and other treatment modalities, supportive care and palliative care, and also primary care. And then thirdly, financing to execute our plan, distribute and implement the framework. So now we are going to transition to the presentations from our speakers. In the interest of time, we won't be doing introduction from each panelist, but first we will hear from Dr. Rolando Camacho and then follow the outlined agenda that you have. So Dr. Camacho, off to you.
Good afternoon, and thank you to Global Coalition of Radiotherapy for this invitation. It's a pleasure for me to be here. City Cancer Challenge was an organization launched by the UICC in 2017. Actually, it was in January. And 2 years later, it was established as a standalone Swiss organization in January 2019. Our mission is to support cities around the world, especially low and middle income countries, as they work to improve access to equitable quality cancer care. So we are focusing cancer care and focusing cities. The cities were, by this time we are approaching, including in this project, are 13 in all areas of the world. And the way that we do the engagement with the city is through the creation of the City Executive Committee, which is a governance body and which is constituted by more than 20 members that represents the main decision makers for cancer care in the city. That include public and private sector, include Ministry of Health, civil society, academia, etc. But also this committee, who is the decision maker people, create a technical committee. And the technical committee is around 23, 25 members, including all specialists who are representing diagnosis, treatment, management, and community access. And when we say treatment, we include also palliative care. So in terms of numbers, City Cancer Challenge has been working with the cities on average 15 to 20 hospitals has been involved, which cover more than 80% of the cancer patients in the city. And more than 200 doctors, professionals, all kind of professionals for cancer care has been participating in the need assessment that is performed in the city. And more than 70 partners has been contributing to the projects that we are developing or supporting in the city. Our partners are mainly international organizations like UN organizations as WHO, as IEA, and also development agencies like Islamic Development Bank, for instance. Also, we have civil society organizations and professional organizations like ASCO, ESTRO, AACP, ONS, International Society of Nurses in Cancer Care, etc. But also we have health institutions, main cancer centers who contribute and support in the training of people who is visiting there for exchange of experience, the Mayo Clinic, Institute Catalan of Oncology, Tata Memorial Hospital, etc. And also we have the private sector. Many of the pharmaceuticals and manufacturers are included as partners. In the case of radiotherapy, our city has been identifying radiotherapy as one of the main priorities to produce projects. In this case, from these first 7 cities that are already implementing projects, 5 of them has decided radiotherapy as one of the main challenges. What is the model that we have for radiotherapy projects? The city's main finding is that they do not have any plan to develop radiotherapy in the city. And also there is a lack of quality assurance programs. So the steps to prepare those projects are first, and it's a standard for almost every project, to designate coordinators and project team coordinators, but also to define the scope and the aim of the city products, what the project is going to produce, and then drafting radiotherapy development plan and requirement for quality assurance program, which is the topic that normally they cover. After that, they have this first draft, they consult this with the peers at the city level. So it's inviting all people who works in that area of radiotherapy, radiation oncologists, medical physicists, RTT, etc., to review the draft and to provide comments. After that, the resulting draft is consulted with international experts nominated by IEA, by ESTRO, by other partner organizations. And then the final product is submitted for endorsement to the city executive committee, and after that, after approval, is submitted to the Ministry of Health for approval. One example of the city, of one of the cities who can be said maybe in other 4 cities something similar, is in the case of Asunción. They identified radiotherapy, the need for radiotherapy plan in the need assessment and quality assurance program. They created a local team of experts. They did a city consultation workshop on the first draft. Then they did a consultation, international consultation with expert nominated by IEA and other partners. And then the national liaison officer of the IEA request to submit the development plan that was prepared for the preparation of the national project in the next cycle of the IEA Technical Cooperation Program. Also, at the same time, the Ministry of Health is reviewing this development plan to adopt as a national document included in the NCCP, the National Cancer Control Program. I think this is one example of how the product developed with the support of CCAN has been going through not only funding, which is the IEA Technical Cooperation Program, but also as a standard document for the National Cancer Control Plan. And then other products that we have in radiotherapy. Based on the experience of the cities and based on the experience of the expert who has been supporting the cities, we decide to produce certain kind of guide on how to. This guide on how to are documents, very simple document, recollecting all the information that is needed for those people who want to prepare those documents, but they don't know how, or they don't want to read the viable guidelines. In these guidelines, they experts recommend documents to be reviewed, groups to be integrated, the way to proceed to prepare the plan, the information that has to be collected, and then the plans, for instance, in the 2, 5, and 10 years. So this is the in radiotherapy development plan, but also we have in quality assurance program, similar document, and also recently it was developed a radiotherapy equipment procurement and maintenance plan for the cities in SICAN, but also for anyone who want to access that in our webpage. And thank you very much again.
Professor Sullivan, we'll pass it along to you.
Super, Darren. Thank you so much. Greetings, ladies and gentlemen, from Belfast. On the meeting here, we're having the anniversary of the Good Friday Agreement. So I've just been asked to say just a couple of minutes really on what the Institute of Cancer Policy has been working on in this space. And I'm going to really focus my comments following up from what Ronaldo said in 2 areas, one on fidelity and the other one on specificity. I think it's fair to say the problems of radiotherapy and the deficits in radiotherapy around the world have been very well articulated now for nearly a decade. It's been outstanding work led by Mary and others, putting forward the case for investment as well. We also have huge numbers of tools at our availability in the forms of guidance, technical support. But the reality is when you look around the world, we still see huge problems in delivery of high quality, safe and affordable radiotherapy. And in some countries, that's actually going backwards. Now, obviously, some of the issues here of the translation of evidence to knowledge lie in the general ecosystem. By that, I mean many African countries now in debt distress. We have huge inflationary pressures. All these have major economic consequences on individual governments and their ability to procure and to supply. But I think one of the things that's been missing generally has been the specificity. A paper that Darren will circulate to everybody, published in Journal of Cancer Policy this year, looked at this in really agonizing detail in sub-Saharan Africa. They looked at procurement, funding, education and training. And what they thought was very, very different issues along these general themes. So equipment acquisition done regionally, for example, in other countries, it's done locally. Financing, in some countries, absolutely excellent and done on a multi-year basis. In other countries, almost none whatsoever. So whilst the generic themes are there, the specificity of the problems in each country is really what's holding things back. And I guess the plea I'm going to make really as we have this conversation, this panel later on, is whilst the overall planning can be generic, what you need and what we're seeing more and more is the need for very, very specific country support around financing, specific country support around procurement and education and training. And within this, a need for more and harder implementation science approaches. These sorts of papers have been replicated all over the world, for example, the Balkan study. So what, again, you're seeing is a real need for specificity and fidelity in translating a lot of the planning and the work that many of the partners you're going to hear from today have done. So thank you very much. I think it's my couple of minutes up. And hand back to you, Darren.
Go ahead, Dr. Hesham. Thank you so much.
So thank you very much for this opportunity. So I'm a physician and public health specialist working as a consultant with the WHO cancer team at Geneva headquarters, where I'm involved in supporting cancer economics and public health programming, as well as providing some-country support in planning and costing. I will share a bit about what, in my opinion, are some of the challenges with cancer planning and radiotherapy and in general, and share some data about the distribution disparities in access to radiotherapy. So from my opinion, the main challenges faced in cancer planning tend to fall into these 3 big buckets: what and when to measure, coordination, and maintenance. The fragmentation and complexity of cancer services in many areas makes it hard to gain the full understanding of the landscape when starting, as information tends to be siloed or gatekeepers might be present. The interest in timelines for the cancer program outcomes might be different for different stakeholders, leading to a misalignment of the goals, which leads us to the fact that unfortunately plans can be developed or implemented in silos, leading to gaps which can limit the efficiency or accessibility for different treatments, cancers, or stages, which is why many implementing partners, including as many implementing partners as possible across the private and government sector, should be prioritized. Some plans tend to lead towards the more aspirational, which can limit their utility. Implementation can sometimes be opportunistic and ad hoc rather than planned, which may reduce efficiency, especially if it's not driven by a common value system or prioritization process. So explicitly stating those might be very beneficial. Finally, maintenance of a plan usually does not receive sufficient consideration, whether that's in terms of the financing, the personnel pipeline, or access to technical expertise. So this is some data we have from analysis we've done of the public health benefit packages in over 100 countries. The full report is expected to be out this September. It looks at what is technically supposed to be covered by the public health benefit packages in each country. Compared to medical and surgical care for cancer, radiotherapy had the widest disparity between the high income and low income countries, with the health benefit packages in a high income country 3 to 5 times as likely to include radiotherapy care compared to those in a low income country. And in reality, we expect this disparity to be even wider, as there's probably a gap and failure in implementation or access, especially towards the lower end of the income spectrum, which is why the work being done here is so vital. So thank you very much, and I return the time to Darian.
Thank you, Dr. Ghaffar. Dr. Skeik?
So let me first introduce myself. I'm Nashwa Skeik. I'm a technical officer. I'm working in the Cervical Cancer Elimination Initiative, which is hosted within the cancer team in the Non-Communicable Disease Department in WHO Geneva. Our department, I will say a few words about what we're doing and how WHO is supporting countries in planning, and that, of course, include an important element of radiotherapy as well. So WHO is is the main technical lead for 3 main initiatives within the organization. It's Cervical Cancer Elimination Initiative, Childhood Cancer, and Breast Cancer. But of course, our work is not limited to that, but also we work all aspects related to cancer control, costing, and other activities also based on regional and countries' needs. We work closely with IARC for research, and we work closely with the International Atomic Energy Agency for sure. And the 3 organizations work closely together to offer the technical support to countries, improve implementation in all aspects of the cancer care. We coordinate and conduct research related to human cancer, monitor cancer burden, and monitor progress of countries. Our team also provides the minimal and the important high impact tools that can help countries in planning and monitoring implementation, and that of course includes cancer control plans. We work closely with other departments as well to strengthen the health system based approach, because cancer is not only a disease, a vertical disease, but rather a cross-cutting issue over many different aspects in human agenda. Our team in HQ Geneva set the agenda for cancer prevention and control. And also we encourage countries to report and monitor progress based on the current status. We provide technical assistance for rapid and effective transfer for best practices, and of course collaborate with partners, and we continue the dialogue with countries in order to understand the gaps and understand the current situation and see how we will proceed from there and how we can improve cancer control. I'm looking forward to the discussion today. Thank you very much. Over to you then.
Thank you very much, Dr. Bode.
So just to introduce myself, I'm a radiation oncologist in Princess Margaret Hospital in Toronto. And for the past 10 years, I've been the head of the radiation treatment program at Cancer Care Ontario. Healthcare in Canada is regionalized in a way into the various provinces, and to head a cancer plan for approximately 14 million people. When we're thinking of developing a plan, we need to look about the supply and demand aspect. But in terms of demand, it's not just demand, it's also need. Need is the right care in the right place at the right time. And also looking at the supply side, looking at what we have in terms of current radiotherapy services, including various aspects, including geography, etc. So I'll talk about those very briefly and how we looked at them. The next slide. In particular, in terms of need, it's the unmet need that we have to look at. And this is not because it's called unchosen, not because the individual chooses to not to have treatment, but because of external factors beyond their control, such as lack of clinical staff, unaffordable travel costs, waiting lists, or other issues, including education. But I think you also need to look at the population in the geographic region, including age, cancer incidence. You need to project that over a longer time period. You need to look at what cancer types you're going to be dealing with, and also look at what your desired radiation utilization. When we first looked at this back in the 80s, our utilization was down at around 29%, and we've now brought it up to approximately 43% in the province of Ontario. So next slide. I think on the supply side, you need to look at our current radiotherapy facilities. And in particular, one of the things that we've managed to introduce is replacement strategies. We know for the next 5 years when new accelerators are going to be placed into various facilities across the province. So there's a plan in place that is supported by the provincial government. We also look at geographic location, and we're developing new cancer centers in particular areas. Also, we think you need to look at safety. Are there processes in place to ensure safe delivery of care, such as we've introduced peer review, incident reporting. Human resources, very important issue as well, and including training to ensure as we bring on new facilities that there's sufficient physicists, therapists, and physicians to staff them. I think you also need to look at capacity and wait time issues. And an important point here is that from a patient perspective, from the date of diagnosis to the date of starting radiation treatment is probably the most important issue. But you also sometimes need to break it down into various other areas and see where the problems are and see if you can tackle the problems within those areas. You also need to also be looking to new technologies and treatment innovations always as you're looking forward 5, 10, 15 years down the road. So that's my contribution. I will hand it on over.
Thank you, Mary. We'll pass it on to you.
So I think we've had a number of presentations looking at various ways of dealing with what we know is the issue, which is lack of resources and lack of detailed planning for radiotherapy. I think that what the contribution that GCR can make is actually to break it down in some kind of workable detailed plan, because very often the plans are made at the government level and ministry level and actually don't meet the needs of facility. And so I think that, looking at the panel, I'd like to ask you is, if you were running a radiotherapy department, what do you need to know in order to plan your resources? And resources include equipment, a trained staff, and provision of adequate quality. And we all know that the quality includes many facets of the treatment needs to be safe, effective, patient-centered, timely, efficient, and equitable. And I think there are several issues about providing quality of care. One is sort of structural quality, which is how do you make sure that you have right approvals, that your radiotherapy facility is safe, it's accredited, it's operating, and it has all the infrastructure that is needed to provide good treatment. And then what monitoring do you have in place to actually make sure that it happens, that the patient who goes through your treatment actually meets good standards of care? Because the data and information that your Ministry of Health has or the regional planning office really stems from you having this data and you providing the data on the need. And in healthcare, in radiotherapy too, but generally in healthcare, we are very reactive. We wait till there is a crisis, and then there's a crisis response, and everybody fixes the crisis. But unless there is a forward thinking and monitoring, all you're going to have is another crisis in 10 years because you're not monitoring the changes in demand, the changes in technology, the changes in type of practice. So I think that would be actually good for GCR to sort of make some kind of a guide of what is it that you need to know at the level of institution, at the level of the population-based cancer practice, and how do you basically prevent future crises and gradually close the gap between what's needed and what's available on the ground. And although, as Richard said, there are various problems in different countries, financing, decision-making. Fundamentally, I think one can put forward a framework that will help any jurisdiction to plan for radiotherapy resources. So going around, maybe starting with Rolando, because you're still on, what is it that you need to know at the level of the institution that has radiotherapy service in order to have the right amount of resources to provide care?
I think, thank you, Mary. I think that and I remember in 2007 or something like that, it was this document from the IEA, what is the need for what you have to consider for planning a radiotherapy department. But I think that really radiotherapy is more than the department. The health system is very important, the whole situation, the situation of the country, and also it is important to, and that's why I think that the approach of City Cancer Challenge is so valid, because it's coming from the bottom up. What is the need for the territory? I don't say city, I don't say country, I don't say territory, because you cannot plan individually, because otherwise it will be something at one level, and then you need to have kind of homogeneous kind of treatment, delivering quality radiotherapy in every place, in the place where you are, in the city or in the country or whatever. So that approach, not the Minister of Health preparing the plan, but the people who works in radiotherapy prepare the plan.
Richard, what do you need to know in order to run a proper operation?
So Rolando's spot on. The big issue at the moment and the elephant in the corner is this isn't a failure at the meso hospital level and the leaders in radiotherapy. It's political failure in most countries. Political failure in terms of debt, political failures not to keep funding maintenance contracts, political failure because of the churn in leadership at the health ministry level. So like Rolando, I think the big issue for us is how you network together at a country level, the meso level radiotherapy providers and the leaders. And again, one of the big issues that come across is a lot of the disasters, a lot of the de-development we see in radiotherapy, or the failure to develop, are entirely foreseeable. It's actually putting in place resilience and mitigation planning and providing enough support and training to those leaders that they can foresee and somehow mitigate some of the challenges going forward. And particularly within the political economy space, there's an expectation, again, that big cancer research leaders are going to be experts in health economics and procurement and contracting. A lot of that expertise is simply not present in those places. And I think there's a real need somehow to build that sort of operational science, that sort of political economy expertise at the meso level into that sort of world. But it's a different way of thinking about implementation and operational science. And it's also a different way about thinking how to build capacity and capability in radiotherapy and delivering it, because it comes underneath it, in a sense, the political radar. But to be honest with you, when you look at that paper I've circulated, this is what comes up again and again. There's a real willingness to try and create these sorts of meso level plans, but the understanding and the capacity to do it really isn't there. Back to you, Mary.
Great. Maybe I'll put Pat on the spot. Pat, you've been at it for at least a couple of decades, if not more, and you work in a country that has supposedly comprehensive national health system without barriers to supposedly access, and yet from time to time there is a radiotherapy crisis. What information is needed to prevent going from crisis to crisis and sort of have a reasonable supply of radiotherapy resources for the population?
No, Mary, thank you. Yeah, and quite frankly, I'm embarrassed speaking from England at this point, actually, because I see the disaster we've got now and the fact that we've decided, somebody on high, that we don't need a cancer plan. We have just lurched completely in the wrong direction, and we weren't in a great place. I'm frankly embarrassed. I think what I've been taking notes furiously on this. I think it's really important that you have to have from it, especially, I suppose our NHS has been dominated by sort of top-down directives that are not necessarily cancer focused. So all this business about what the patient needs, put them at the centre of it, the professionals working totally together with industry and the whole mix of physicists and whatever, getting that leadership together to deliver it. But then, as Richard says, people haven't got all that knowledge. I don't have all that knowledge, different things and pieces. And it's it's almost as though we need some specialist resource we could access to add it all in. So how are we going to get this over the line? Our biggest problem in the UK is that the people in power who are making these decisions do not know anything about radiotherapy. And that's the problem. And I think the gap between the knowledge gap is massive, and it's always put in the sort of too difficult to deal with box, or the an afterthought. And we've got to bring it right center stage now and have it with people who know what they're talking about. And probably each country doesn't have enough expertise themselves at that level. And if we could share that resource, that will be hugely useful, rather than everybody duplicating it themselves, because we're not going to get. So I think out of this, if we have some sort of structure where we can share that top level thinking, would be absolutely massive, rather than everybody try and reinvent the wheel and fail miserably.
Thanks, Beth. So there are several people here from Canada, from Ontario. Those of you online may not know that more than 30 years ago, or over the last 30 years, we had a couple of situations in Canada and Ontario, rich country, good healthcare system, relatively speaking, where we actually had to send the patients with cancer for radiotherapy outside the country because there was no access within the country. So maybe I'll ask Parik Ward, and I see Tim Hanna online, and I also see Jake Van Dyke online. But all of them worked in the system, and Tim specifically has done a lot of research to look at the access to radiotherapy. And Parik, chime in, and maybe you can add, how do we make sure that the people who are in decision-making positions understand what their needs for radiotherapy? How did we make it in Ontario? How did we make people understand what the needs are? Who wants to start? Parik?
Yeah, I'm happy to chime in. It's I think I've been listening to other people talking over the last little while, and it's the political will. I think the fact that we had to, in 1989, send patients out of the province for treatment in Ontario is still remembered in the Ministry of Health and in the political domain. It was considered a total disaster politically, and they don't wish to ever see that again. So that actually led to the major investments over the last 20, 30 years, so that they don't say it. It's not that it's perfect now, it isn't, but it is still remembered within the ministry and within the political domain. It's considered, one of the things about Canadians is they like their free healthcare. They consider it very important, and the thought that it absolutely failed to them was not acceptable. So it's you need to keep this in the political domain. And clearly, I think it also helps that one of the things that we had was an outside body, to a certain extent, monitoring the system and reporting to the public. I think that's also a very useful thing. It was the Cancer System Quality Index. It became perhaps a little bit too detailed. But the concept of having an independent body saying, you're actually doing okay here, but actually you should do better in this area, I think is also an important point. And that was helpful in keeping it and being reported on once a year and getting to all the newspapers and such. I think that was helpful. So I'd see if Tim has anything to add.
What data do we need, Tim, to persuade people of how to secure adequate access to radiotherapy?
Yeah, it's a good question, Mary. And I completely agree with Parag that there's a massive political component. I think to move an access agenda forward, there's also, of course, as Parag also alluded to, a need for information and data. There has to be, I think, that convergence of good information plus that politics and public face political will. I think first and foremost, you need to have numbers on what supply and demand is. And I think that gets to Richard's points about understanding the specific problems that are affecting the system overall and then at a smaller level. I think that's first and foremost, and then you can start to get into the weeds after about smaller issues for specific cancers, but having just that general understanding of where the big gaps are in terms of equipment and personnel is crucial.
Can you expand a little bit of what data do you think we need in order to make the case, and how this data, I'm aware that for city cancer charge and anyway, when people plan, they look for data on the supply and demand, but talk a little bit about the maintenance of this information going forward and over time, rather than one-time only data collection for the purposes of planning.
Yeah, so I think first and foremost, you need a functional cancer registry. That's the backbone of any of the planning that needs to happen. Keeping track of personnel relevant to radiotherapy, and I think also understanding who is getting radiation. Even just radiation, yes, no is helpful. And then from there you could start to get into the weeds about dose fractionation, et cetera. But even just cancer registry and just very high level, who got radiation, who got systemic therapy, who got surgery, I think can be helpful. And then beyond there, starting to get at stage. But even those simple things can go a long way in monitoring populations. And then if there are specific issues, like specific population groups that you're concerned about, demographics can be helpful in honing in.
Maybe you'll go back to our panel, Dr. Ghaffar. Maybe you can talk a little bit. We talked about integration between radiotherapy and other elements, but if you were only to focus on access to radiotherapy, what do you think from WHO point of view are critical? What is the critical information that's needed in order to secure adequate supply of resources?
Thank you very much. So I have to reiterate what Rolando and Richard said, that the action at the high level alone is not sufficient. You need on the meso and local level, because a lot of some of the things we see, especially in radiotherapy and radio imaging, is the supply might be there, but then it's behind the wall in the private sector or with high costs. So that alone is not enough. We need to look at what are the drivers for inequality in that area, what is needed to maintain these equipment. So we've had experiences where a country with a linear accelerator drops out because the software needed to keep it running needs to be updated, but the process to purchase the updated software takes 2 or 3 months. So we need clearer understanding of what's needed to maintain these, both the software and the infrastructure. Low-tech solutions for high-tech equipment is necessary, which is being developed in manufacturing industries as well. And we need to learn from those and try and develop it as much as possible for the local context, rather than, unfortunately, in radiotherapy in particular, we take recommendations and adaptations from high-income countries and try essentially to fit them into the low-income countries and hope they work. Thank you.
Thank you. Anybody else? Nashwa, you want to chime in?
Thank you very much. I mean, I like the fact that we're discussing this from top, it's from down to top. I do agree that political will is important. Decision makers, stakeholders, having partnerships in the planning process, and the commitment from the government is essential. But I still believe that facilities and even district level information are still so important, and they play a major role in feeding in information to those at a higher level. As we all know, people in the government, they really don't know everything about radiotherapy and its specifications, but it is still the responsibility of people on the front line to be able to monitor progress, collect data, understand their needs and the gaps, and feed all of these information in a continuous manner and flow that help decision maker identify these gaps. I don't think political will alone is enough, because politicians and people at higher level, they will buy you equipment, they bring the equipment in, and as Hisham has mentioned, they're all just put there are gaps in capacity building, gaps in data information and quality of these information, monitoring and evaluation. And unfortunately, all of these plans will go unoperationalized and in vain. So I think there are efforts that should come from both sides, from the higher level, but also from the bottom as well. Thank you, Mary.
Thank you. So I see Katie Wakeham from IAEA. Katie, do you think that we have enough information of how to, what to include in cancer plans, and as far as radiotherapy resources are concerned, together with how to maintain and collect the data on appropriate access and quality, and how we meet the population needs for radiotherapy, or is there a need for more guidance? Katie's on mute. Anybody else would like to chime in? Pat, do you think that we have enough guidance, or is there a need for sort of reevaluation of the information that we need?
Yeah, no, I think, yeah, and it would be good to be clarify the information that would make up the whole, and what have we got already, how much information is there. I was just thinking of the HERO data has been hugely useful, and how much update, particularly I'm thinking in terms of going forward. I know in the UK, CR UK have said now there's going to be a massive more explosion in cancer cases than they thought due to obesity. They've put their figures now up to 500,000 a year by 2040. So it throws our current things slightly out a bit as well. So we could do with sort of what are those cornerstones for what do we need, and then how do we update them completely, because I think some of the data is out of date now as well.
Okay, Dr. Qureshi, you have your hand up.
Hi, this is Bilal from Pakistan. So I have 3 comments regarding I think it is very important to have trained manpower as we go on with the planning of any radiation therapy services as part of the National Cancer Control Program, or otherwise within the regional level as well. That does not only include radiation oncologists, but adequate manpower of medical physicists, technologists, as well as the clinical engineers, because that is clinical engineering is somewhere where many developing countries struggle because of the lack of direct vendor support. People may end up getting only one linear accelerator with limited support, so that keeps on piling up the waiting list or even delays the curative radical patients. So a continuous structure to have manpower available with catering the needs of continuous professional development of all these 4 quadrants, especially the clinical engineers, because we talk about the rest of the 3 quite a lot. The second thing is like providing some sort of support in selecting the software and the hardware for any new radiation oncology center, because talking directly to the vendor with funding available out there, a new center may not actually be able to select what is the right modality that you need for your particular center, for your cancer patient, especially the curative one. People end up buying very expensive, for example, equipment for intraluminal brachytherapy for esophagus and bronchus, but that does not have any major role in curative treatment. You could spend more on imaging or immobilization devices to have good systems there to treat your curative patient. And third is for many important areas like pediatric radiation therapy, which is very much curative, but in a bigger picture where most of the clinical oncologists or radiation oncologists are adult cancer care, the very important curative aspect of pediatric radiation therapy is ignored. So you need to have site-specific expertise for them. So those are the 3 points I wanted to make quickly. Thank you for giving me a chance to speak.
Thank you. Does anybody else want to comment about the need for comprehensive human resource plans for radiotherapy? Certainly, that's a challenge in many jurisdictions, especially with the shortage of medical physicists in the world. Any comments?
Yeah, Mary, it's Porrick. I mean, I think it's the first crisis we had in 1989 was actually due to a shortage of therapists. And it's still remarkable to me that actually in 2023, in one of our provinces, that actually half of the radiation machines are not working because of shortage of therapists. So it's something that you have to actually plan for and also monitor as you go forward. It's not just therapists, physicists, and radiation oncologists, but it's a huge issue, the HR issue.
Mary, do we think, Pat here, do we think that we also suffer from everything being in silos? Because I know in the UK we've got different colleges, nobody's comprehensive. Even in our government, we've got people doing with equipment, different sections doing with HR, all these types of things. So there's nothing that gathers everything all together, both on a sort of professional front as well as then on a political front. It's always in different boxes. And I think that's a massive problem. And that's why in some ways, if in part of our planning with the GCR, if we can call that out and actually recognise that, because you should have technology across the board, not just know it. Say you may know the physicist, but you won't know the therapist, and you've got to all integrate together. I suppose one mission of the GCR has been basically the whole radiotherapy family needs to come together and therefore address those political and practical things together.
Sure, I agree. And we have a couple of hands up. Maura, Mel, your hand was up for a while.
Hi, I'm Mora from Cambodia, a radiation oncologist, and I think I agree with Bilal. One thing that we need to focus on is like in Cambodia, I think IAA has known us well. We have set up the modern radiation facility for 5 years, but then we get stuck. We still deliver the service to the patient, but we can't expand it. It seems like we still lack of human resources, and the core team that are running the machine, including radiation oncologists, medical physicists, and therapists, still are so occupied with all the daily work. So they don't really have the ways to expand the team. Like we don't know how we can expand further, like by setting up local program. So we are looking at what kind of support we can get the core team to expand their capacity further in order to get more people. And one day, hopefully, we can have the support to create the local training program, so we don't really have to look for people and send them out all the time.
Thank you. Nashwa, you also have your hand up.
Yeah, thank you very much. I mean, and the training aspect, I do believe that we think about the workforce who work in the medical health the facilities, but also we should not also overlook the engineers who are maintaining the equipments and the radiotherapy machine. We know that there's a huge gap in low middle income countries. I mean, a whole machine could be thrown away just because there is no engineer who can maintain a machine. And the government has to look for ways for cost effectiveness and be able to make the decision, the right decision, based on the capacity that they have. And it's something that we are also stakeholders and partners with the government to support with. And we should keep in mind that it's also a benefit for cross-cutting department and entry points within the health system. So it's not only for radiotherapy. Investing in this area and not only, but keeping in mind the capacity building for the workforce, engineers, and everybody who come together to offer this service is essential, and it's really cost effective. And we should help countries put them on the track in the planning process.
Thank you. So, I think we're talking about radiotherapy planning and planning for services that meet the need of the patient, making sure that we have adequate facilities with equipment, with people with skills who can deliver care with right quality. And then how do we maintain this service over a period of time and respond to changing needs? Because a number of people talked about, increase the number of cancer cases, changing profile of practice. Park talked about implementation of new technologies. How does this whole thing work? Pat, I'm gonna pass it over to you. Do you think that there is a role for this body to actually do some work on that? Because although it's complicated, it actually, because of the way that radiotherapy is structured, one can actually put a framework in place to address all those issues, the issues of meeting the demand for the patient population and providing quality radiotherapy, and making sure that we have the right information to provide to planners and ministers and decision making on an ongoing basis, so we don't get surprises because we've developed new technologies. Nobody thought about how does it impact future need.
No, absolutely brilliant. I think what I've got from today is quite clearly that if internationally and globally we had a framework, and so the speaker's been great, very clear, some big topics, very good framework in what needs, what data is needed, what feels in, to almost have a sort of minimal standard that everybody can work to, and also ongoing, because I think without that, everybody's floundering in the dark, and I think it's got harder with new technology actually, because it's a much bigger gap now. So I think if we could come out of this and develop that standard and what is needed and a global guide too, it would be a massive step forward.
So how do we do that, Pat?
Well, we have collect our data from today, and we have our second meeting, and then perhaps a working party should actually start drafting this. And as Richard said, perhaps we can pull in those other people from other areas, not just radiation oncologists that we need in terms of policy and statistics and those sorts of things. I think it's everybody here has that insight and actually can do this and has the contact. So I would suggest we get a working party, perhaps led by yourself, and we really deliver on this. I think it'd be a huge step forward. What does everybody else think? And also, I suppose industry, we haven't heard from industry as well. How can they, because we want them to contribute as well. They've got a lot of information. Therese, you're on, or Shandy?
Yes, hi everyone. Hi, Pat. This is Therese from Electa. I just wanted to add to, great conversation. Just to add to that, we discussed a lot what is on the demand side, on locally on the ground, but also representing a business. It has to also be possible for a business to make business, meaning, political stability, risks, etc. So that's also something that has to be taken into calculation in order to build something in each and every country. So it's a lot about political stability. I think some of the other speakers talked about that a lot too, how important it is with that.
Great.
We have a few minutes left. Is there anybody on the call who works in the system that's perfect and has it all figured out and provides good radiotherapy, good quality, good access with no problems? Silence. I think in a number of jurisdictions, we did make progress maybe, I don't know, Tim, Hannah, are you still on? Maybe you can talk a little bit about what we know about meeting the population demand for the right utilization of radiotherapy, and how do we go about maintaining the high standards of decision-making around radiotherapy?
Sure. So I think that once there's that will and investment, monitoring is incredibly important, and having policy advocates or political brokers that are baked into the system to help ensure that the smaller level needs are seen and addressed. We have regional VPs of cancer care in Ontario, and that allows an understanding of what's happening at a smaller level that can feed into the larger system. And then I think having clinicians that are involved in leadership is valuable, because there's a practical understanding of what needs to happen to ensure that all of the pieces fit together. And then on an ongoing basis, having specific targets. You know, you can't measure and address everything, but if year to year you have specific goals and targets that can be set in place to improve things, that can be valuable.
Anybody else wants to chime in? Maybe other professions, Jake Van Dyke for physics. What role do you think physicists should have in planning for radiotherapy resources and quality of radiotherapy?
You're on mute.
Try again. Thanks, Mary. So clearly it's a team activity, and we've talked about silos before, and there's multiple people involved in planning facilities, and all members that are from the different professions should be part of that team process. And so it should not just be the leaders that make the decisions about how the technology is moved forward. It should be a combination of the people directly involved in carrying out the service. I just wanted to raise a question from the discussion before, and that is the issue of political will, and that's come up consistently throughout the discussion. And what hasn't been discussed, I don't think, in very much detail is how do you create political will? And I think the crisis in Ontario in 1989 hit the news. It hit the public news media, and it was publicity that generated the politicians to act. And it was that component of it that created political will. So and that works in some countries, in some circumstances one way. It'll work in other countries and other circumstances another way. But I think the issue of how do you create political will should be addressed, because I think that's a very important consideration.
I think that's really important in terms of so important, and that's why we've obviously got our the GCR has done an advocacy toolkit. I think we have to have advocacy alongside all of this. I know in the UK we've had a monumental effort in terms of political push, but that has been total media push as well. So the two do go hand in hand, and I think we mustn't forget totally advocacy out there as well to the general population to then feed into the politics. So Mary, you probably need to wrap it up now. It's fantastic.
Yes, I think we've sort of have the last 2 minutes, so I'll hand it back over to you and Darian to finish and make plans for the future.
Yeah, and I want to thank Mary. Thank you so much for moderating this. We needed your wisdom, and thank you for the panelists, and thank you for all attending. We had over 100 registrants, and it's been recorded. I saw 59 on at one point. This has been really important. I think this is really exciting for the next stage for radiotherapy globally. Also, we just wanted to say we're celebrating our 3 years as the GCR. We're just going to launch our impact report, so we'll be sending that to you in your inboxes shortly. And so we'd also love to have your input about how we can do more, not just on this area, but in other areas as well. So we have got a survey as well. So please fill that in. I think we've got all to do this together and we can do a lot. So I'll give the final word to Darian, and thank you, Darian, for organising this so well.
Thank you so much, Pat, and thank you everyone for joining us. And as Pat mentioned, please take a moment to fill out the survey. That is at also in the link is there in the chat box, and we will be sending out to everyone, as well as the recording from the meetings, the paper from Richard, and the slide decks. Thank you all for attending, and thank you so much for being a part of the GCR.
And we look forward to on part 2 of this, which our date for that, Darian, is June
13th.
June 13th. So we'll do a lot of work in between time, and we'll meet again on June 13th and move on with this. Thank you so much, everybody.